Great, thank you, Anis. I appreciate everyone coming onto their virtual devices for our journal club. And hopefully, please let me know if I'm not transmitting or my audio is poor, and I will adjust. I do have a headset and a microphone in, so it should be good. For today's journal club, the article selected is one that is based on EMS. It's and for many of you, this may be a relief. It has nothing to do with the current COVID-19 pandemic. It's back to the basics of what we had been doing day to day before the pandemic began. The article is written by authors from Peking, China, university in the main university in China, and it's an assessment of the. Let me bring up another slide here. It's a really an assessment or a look at the survival from out-of-hospital cardiac arrest with use of dispatcher-assisted CPR. Dispatcher-assisted CPR, it's well defined in the article. I'll just summarize real quickly is I think almost everyone on the journal club today knows, but just in case it is, and to define it, dispatcher-assisted CPR is when someone out of hospital goes into cardiac arrest, collapses, and one of the rescuers calls 911 in America or EMS in other countries, 911 in the United States, sorry, or EMS in other countries. And the dispatcher, upon immediately identifying that there's a potential cardiac arrest, begins to coach and give information to the rescuer or rescuers with regard to doing CPR. And currently throughout the world, CPR, when it is given through dispatcher assisted instruction, is chest compression only. So we're talking about the basics of CPR. A couple of things about introducing the article. It's well known that survival of out-of-hospital cardiac arrest depends on early recognition and the rescuers acting in a sequence of events or interventions. The chain of life is a term that's commonly used in many areas, but it's basically recognizing, doing CPR, accessing emergency services, and then applying advanced life support, transporting to the hospital. In the out-of-hospital setting, most often layperson bystanders, in other words, non-medical personnel, are the ones that witness the cardiac arrest. And if the cardiac arrest is witnessed and CPR is promptly started, EMS is notified. It has been shown in many articles going back 30 to 40 years that survival is possible, for one thing, and that survival is better the sooner and more promptly the actions are taken and the sequence is taken in a prescribed way, as I just described earlier. As I said earlier, bystander chest compression only CPR has been shown to be safe. There are articles that question whether it's safe because of rib fractures and chest contusions, particularly in older persons. But by and large, chest compression CPR by someone not trained or trained in CPR has been considered safe, and the benefits of potential survival far outweigh the risks of complications. So the study objective for our paper today is it's a systematic review and meta-analysis of current research aimed to evaluate the impact of dispatcher-assisted out-of-hospital bystander CPR on victim survival and neurological outcome for cardiac arrest. The study objective, it's very, very important when you look at this paper as well as any other paper. The study objective in this paper is very well defined. It is one that is precise, and for, excuse me just one second, for systematic reviews in particular in meta-analysis, it is required that a study objective have a very concise and, or I should say precise outcome measure. Generally, study objectives for a systematic review and meta-analysis do not have multiple objectives or hypotheses that are tested. And one of the reasons that this article was chosen is because it is a classic systematic review and meta-analysis. So as much as discussing the findings of the study, this journal club is directed to reviewing the proper way to do a systematic review and meta-analysis. So this is a systematic review that is looking at outcome, survival basically, of cardiac arrest in the out-of-hospital setting. Another important thing about the study objective is that the authors are looking at survival, and as we go through the article, you'll see that we look at survival to hospital discharge and good neurologic outcome. Many CPR studies and EMS studies look at return of spontaneous circulation, or ROSC, or hospital admission, but the standard for many years has been, with EMS research on out-of-hospital cardiac arrest, the standard outcome measure that is used to compare different studies is survival to hospital discharge and good neurological survival or outcome. So this study is a very, very well-designed study that was just recently published. As I said, the study method is a systematic review and meta-analysis. These types of studies are very difficult to do. The journals, whether it be Pre-Hospital and Disaster Medicine, British Medical Journal, Annals of Emergency Medicine, JAMA, or the New England Journal, journal editors actively seek these types of studies, these systematic reviews and meta-analysis, because it consolidates, it really brings together all the prior literature and often will result in a very precise and definitive answer for areas that may be controversial or vague with regard to whether there really is a good outcome or not. For example, this one's looking at dispatcher-assisted CPR and whether it really matters or not in the out-of-hospital setting of cardiac arrest. So these systematic reviews and meta-analyses require very strict adherence to study standards. And in the second bullet here, I've actually given the study standard used by major journals throughout the world, and that is the preferred reporting items for systematic reviews and meta-analysis. For short, we call it PRISMA. The PRISMA checklist and guidelines are readily available on the internet. Just Google PRISMA guidelines and it pops right up. The most current ones, the 2020 ones, have just been revised So they undergo revision occasionally. And really no journal, this is very important for those of you that are early in your careers, no journal editor would accept a systematic review or meta-analysis unless it follows the PRISMA guidelines. These are international agreed upon standards for publishing this type of research. The reason this type of research is so standardized is to allow for comparing systematic reviews of the same or similar topics so that researchers and clinicians can determine by comparison of work that is done under a standard protocol, can compare the results to determine whether they're really significant or not. So a systematic review uses, moving back up to the upper bullet, is a priori, in other words, before the review is done, systematic and clearly defined methodology aimed at limiting bias in the evidence that is used to answer, as I said earlier, a well-formulated research question. A meta-analysis is really an extension of a systematic review in which there is actually statistical data analysis of all the data that is pulled together when a systematic review is done. Meta-analysis are very highly sought after types of research, again, by all the major medical journals throughout the world. As you'll see as we go through this paper, a meta-analysis can become very, very powerful in bringing data together from many different researchers and combining that data to answer a question. There are other types of literature review methods. A popular one now is scoping review. And some of you may have done a scoping review or be considering a scoping review. It's very different from a systematic review. It is not, from the journal editor point of view and from really a scientific review, it is not considered to have the highest quality that a systematic review does because the methods are not as set as the methods used in a systematic review. A scoping review is where a author or authors pull together preliminary data that they're aware of on a topic, let's say out of hospital cardiac arrest, dispatcher assisted CPR, where one would pull together papers that are already known or available to those authors. Those papers are reviewed, and then other papers are added, other research is added as the review is continued. Often in a scoping review, a type of research called snowballing, where more and more papers are brought in based on looking at bibliographies or references to a few original papers are brought in to try and determine a discrete, actually a idea as to where the current evidence is within the literature. A scoping review is not considered a type of review that can provide an answer to a well-defined research question, as I just emphasized, is the objective or the reason for doing a systematic review. There are PRISMA guidelines and checklists available also for scoping reviews at this time, and those are freely available with just a Google or similar type of search of the internet. Other reviews are narrative reviews. These are often the types of reviews that are done in the introduction of research papers or a thesis, excuse me, a thesis for one's doctoral degree or master's degree. These are just narrations by the author of the research that they've found in a field without detailed searching of the literature. Critical reviews are another type of review where, again, it's non-systematic, but it's a look at the current research to see, to assess and compare perspectives, critical perspectives on a topic to define really what the current controversies are in a topic. And the same is true also of a state-of-the-art review where, again, without using systematic methods, the authors pulled in literature, not necessarily all the literature, but what's freely available to them, maybe only limited to the last 5 years, where they're looking for inconsistencies and disagreements on a topic. So there are many types of literature reviews. Often people who are not familiar with particularly the medical literature or the health literature assume that all reviews are done systematically, and that is really not true. And the reality is very few systematic reviews and meta-analysis are truly available in the literature. It's often the other types of reviews as described on this slide. So let's get back to the paper that was selected today for the Journal Club. The articles that were reviewed, when one looks at, again, this would be, I'm actually one slide ahead. Nope, there we are. The articles that were reviewed are described, or how the articles were selected were described in the methods section, and I've really pretty much described the methods section as a systematic review. A couple of things about that methods section is that the types of articles, the inclusion criteria, and the exclusion criteria, we really don't have time to do it now, but those are very clearly defined. The sources of the literature, where they, like PubMed or Scopus or other databases, those sources of literature are defined. In this study, the inclusion and exclusion criteria were well defined. All sources of published literature that is in peer review literature were searched, and the authors went so far as to also look at reports and posted PhD or doctoral theses and master's theses from university databanks and databases that are available. They were not able to find any randomized controlled trials. The best systematic reviews limit themselves to randomized controlled trials, but this one could not do that because a randomized controlled trial of dispatcher assisted CPR would mean not allowing the dispatcher to instruct someone in CPR, which basically would be unethical. So already we do have a limitation of this study, but again, they're pulling the best literature they can. They came up with 13 articles out of 1,156 articles that really met their strict inclusion criteria after applying the exclusion criteria. And these articles were often descriptive in nature. There was one case-controlled cohort study They were descriptive, for example, before and after studies. So they were quasi-experimental studies, relatively good for generating data, which is what's going to happen with the meta-analysis. In the meta-analysis, so of the 13 papers, they combined all the cases that could be analyzed, and there were approximately 97,500 dispatcher-assisted CPR cases versus, in this literature, in the 13 papers pulled, over 137,000 non-dispatcher assisted cases. And these were found within 11 articles, really. The papers, and the authors repeatedly point this out, had a substantial heterogeneity, meaning that the papers did not, they were written often with different inclusion and exclusion criteria. Some papers, for example, were only adult out of hospital cardiac arrest. Other papers included pediatric out of hospital cardiac arrest. So there was variation in the papers that were reviewed for this review, this systematic review. And heterogeneity is another problem with limiting a systematic review. If you're really deeply interested in the techniques and methodology of how to deal with heterogeneity, the authors explain doing funnel charts, funnel graphs, and they took a number of steps to work with making the data, the 97,000 and 137,000 cases in the two comparison groups, comparable. So there are statistical ways to deal with heterogeneity, and the authors in this paper did a very good job of that, and it's described in the statistical analysis section of the methods section of the paper. So I think most of you are likely not as passionate about methodology and how the research is done as I am. So let's get to the main findings. The main findings are really very striking. This paper was just published this August, so it's just now come out. The main findings included the following outcome measures. And one was that dispatcher-assisted CPR favored return to spontaneous circulation in the field. The odds ratio was 1.17%. There's a slight favoring of ROSC in the field. The confidence intervals are convincing clinically because the lowest confidence interval is above 1.00. So ROSC in the field is clinically significant. They also used chi-square methodology to show that this was statistically significant with a p-value less than 0.05. They interestingly found no significant difference in hospital admission. The odds ratio was above 1.09, so there was a better than a 50-50 chance that one would survive to hospital admission. But the confidence interval, as you see on this slide, drops below 1.0. So one cannot say that for hospital admission, the odds ratio is clinically significant because of the spread of the 95% confidence interval. Let me make a comment about 95% confidence intervals. It is very rare in many of the papers that journals that I review for. It's no secret that I review for the British Medical Journal, the New England Journal, Journal of American Medical Association, Annals of Emergency Medicine, and also then I'm editor with PDM. So I'm very familiar with many medical health journals, and none of those journals would publish an odds ratio, a percentage, which is a proportion, or an average or mean without accompanying that measure being accompanied by a 95% confidence interval. These confidence intervals are extremely important in health and medicine for determining whether the measure of central tendency, which would be the odds ratio here, is truly clinically significant. And we'll see in the next two that dispatcher-assisted CPR favored overall hospital discharge versus no dispatcher-assisted CPR by a very good odds ratio, really, of 1.25 when you consider the low survival rate for CPR out of the hospital with a very convincing confidence interval. And then most importantly, dispatcher-assisted CPR favored better neurological outcome, again, convincingly. So this study is now, this meta-analysis has now answered the question of whether dispatcher-assisted CPR does improve outcome in out-of-hospital cardiac arrest. It is an article that should be in the future one that becomes one that's called a Sentinel article or a major reference article, because it supports in emergency medical services, pre-hospital care, implementation and financially supporting and training dispatchers to do CPR. This is one of the reasons this article was chosen. Another comment is the authors report ROSC, they report hospital admission, they report hospital discharge, and they report neurological outcome. The neurological outcome was measured using the cerebral performance categories or scales, which is a very standard one in CPR. These sequences of findings that they report are based on the Utstein guidelines for out-of-hospital cardiac arrest for research in that field. And the authors report that, which is again an international standard in doing this type of research. In the discussion, the authors pretty much showed what I just talked about. One thing they do discuss is that the study included both childhood and adult cardiac arrest victims. They did not assess the effectiveness of automatic external defibrillation and whether those were available. This is another area that has convincing evidence for implementing AEDs, but really needs a good systematic review and meta-analysis using the current literature, modern and older. The limitations of the study is that, as I pointed out earlier, there were no randomized controlled trials. Those types of trials are the highest level science in any of the health and medical areas of research. The articles recovered for analysis did not all have calculated odds ratios, so the authors themselves had to use statistical methods, manipulate the data presented in the articles to fit them into their meta-analysis. That means the statistics in all the articles were not of the highest quality. And there was considerable heterogeneity, the papers, which I already talked about. And during the papers reviewed actually dated from 1976 to recent, so there have been changes in recommended CPR, with now the emphasis on chest compression only CPR that I had talked about earlier in this journal club. And as I pointed out earlier, a limitation is the inclusion of childhood and adult cardiac arrest. Children usually have a arrest either from hypovolemia or respiratory failure. Adults, it often is, well, in adults, we begin to include and becomes more and more common to have primary ventricular fibrillation or asystolic cardiac arrest. So we're looking at a mixture of different types of arrests. So this is not specific to the ventricular fibrillation arrest that many of us in this area really focus on trying to get a defibrillator to the scene as quickly as possible. Excuse me. So the conclusion for the paper is that the dispatcher and assisted CPR is optimal in the sequence of actions that should be taken in out-of-hospital cardiac arrest, and that it improves the rate of survival and neurological outcome. And as I said, the article, the paper supports the implementation in systems that have dispatchers that dispatch emergency medical services being trained to instruct callers in how to do CPR when cardiac arrest can be recognized by quick information given by the caller. So with that, I will open the forum for any questions or comments. I really do appreciate everybody who has signed up and logged on, if you will, for the virtual journal club. I look forward to future journal clubs, and I hope that not only the article, but the discussion of systematic reviews and meta-analysis is helpful for all of you that did log in. So I'll open for any questions or comments.
Thank you, Sam, for that. As Sam just mentioned, we are at the point of the virtual journal club where the remote audience can ask questions. As Sarah indicated at the beginning, you can click on the question mark icon to type a question, or better yet, click on the hand icon and you can raise your hand virtually, and we'll unmute your microphone and you can ask a question directly to Dr. Stratton.
Well, till we receive questions, I would like to really thank Dr. Sam for this lovely presentation. I was looking forward for it. And actually, I have been always recommending the editorials written by Dr. Sam in the PDM journal for my students and trainees, because it really bridges the gap, especially for young or entry levels of our colleagues, where they will feel the gap or the chasm between the clinical practice and the clinical epidemiology. And it's really sometimes could they would face difficulties in how to relate to all this study designs, biostatistics, the basic stuff at least, not as a statistician, but rather than a clinician who really needs to absorb all the ongoing and quickly updates that's happening in clinical medicine. So this was really enlightening, and as an extension for the usual editorials run, I would really recommend all the audience to go through Dr. Sam's editorials. It will feature so many aspects of the common problems we can face and provide answers and framework on how to tackle it. Maybe my first question I will, if I may, Dr. Sam, is given a situation where like this, I have a very original question. I need to do a systematic review, but the problem is the heterogeneity and the quality of the published articles. What are the tricks that I can do to come up with the best answer, but still I can not push beyond how to be a high quality study. How to draw the line and how to tackle this challenge, please.
Yes, so heterogeneity in the literature is a problem when considering a systematic review. There are very, how do you put it, sophisticated statistical measurements or methods to deal with heterogeneity. And in this paper, the authors used very sophisticated methods. One of the ways that can be a systematic review and meta-analysis can be done, even despite heterogeneity, is to, one, assess the quality of the papers, the quality of the science, and then rank the paper. And this is one that I recommend for, say, someone working on their master's thesis or even a PhD thesis, is assess the quality of the literature. And let's say you have 10 papers that you can put into a systematic review, and 2 of those papers are high quality, and let's say 6 of the papers are medium quality and 2 are rather low, high biased quality. You can do your review first by doing analysis or drawing a conclusion off of the 2 high quality papers, then adding the lower quality papers in to see if, and report in the paper, in your publication, whether these papers add to or neutralize the high quality papers, and then add the lower quality ones in. So researchers can often do, put the papers into hierarchies and categories, and then by category analyze, look for their research question to be answered. If high quality and medium quality papers give the same answer, then your answer is very, very strong. And it is likely, although you have to list it as a limitation, that data is good enough to do a meta-analysis upon.
Okay, many thanks. So, Dr. Sam, the first question from the audience is, can you please provide your opinion on scoping reviews?
Scoping reviews are, so to do a meta-analysis, the literature has to be there. You already have to, you have to be confident and you have to be aware and know that the literature is available to do the systematic review. In other words, you are aware that there are papers that will answer your very specific question. A scoping review is often done before a systematic review is done. And I realize, at least at UCLA, where I do a lot of work with graduate students, I realize that scoping reviews often are the total of one's, let's say, master's thesis. Scoping reviews are done to show the strength of the current literature, gaps in the literature, and the need for further research on the topic. They cannot answer a specific question as this paper did. So scoping reviews are, for example, I would like to find out what the literature reports with regard to survival to being neurologically intact with the use of AEDs in, let's say, a certain setting, in subway train stations. You would begin to look for that literature, and if none exists, then your scoping review shows this area needs to be researched. If there are papers, then you would say these papers are present. We've looked for further papers and found a few more. So this scoping review shows that likely a systematic review can now be done on this topic. So scoping reviews do not answer a specific outcome question. They show the status or the status, if you will, of the current literature regarding a topic.
Okay, so, and also, Dr. Sam, a follow-up question. Are scoping reviews viewed favorably in medical literature, or should we focus instead on systematic reviews, even though they make more time? Oh, sorry, may take more time.
Scoping review is not looked upon as favorably, obviously, as a systematic review. For example, in pre-hospital disaster medicine and most other major journals, scoping reviews are published as special reports, or for example, in the British Medical Journal, Lancet, and the New England Journal, a scoping review would be a research letter to the editor. So they don't often in major journals qualify as original research or a systematic review, which if you go to the instructions for authors for any journal, it'll clearly describe it. In lower level journals, what we call the B category journals, scoping reviews do get published as original research. So the answer to the question is they're not as highly regarded as a systematic review. A systematic review and meta-analysis is regarded much higher than just a systematic review, and both are regarded much higher than a scoping review. But a scoping review is considered much better quality than, let's say, a narrative review or some of the other reviews I discussed. So scoping reviews are publishable, much more difficult to be published because there are very, very many of them that come into the journals. But they are publishable, and they do add to the science because they describe the state of the literature. So hopefully that answers the question.
Yeah, for me it does, and I hope also for the person who asked the question. So, Dr. Sam, I really enjoyed the presentation. It was my utmost pleasure, and although we were planning to have it only as 30 minutes, but we are past due by another 20 minutes, a total of 50 minutes. But it was very enriching presentation, and we look forward for having you again for more such rich presentations and other topics to discuss. So I think we can leave it here, and if there is any final comment for you before we close.
I appreciate everybody logging in and for this virtual journal club.
Okay, so at the end, I would really thank Dr. Stratton for his time and presentation, and also I would like to thank our dear colleagues Andrew and Sarah for hosting this journal club. So everyone, wherever you are, have a nice day or night, and hopefully see you next time, inshallah.